Good morning. This morning we're going to speak about a very interesting topic that was published in the beginning of this year in an article that we'll give reference to just now. It was entitled US-guided or ultrasound-guided musculoskeletal interventions in the hip with MRI and US correlation. So the original article was, as mentioned, the title there, and these were the co-authors and author. They published this article, as I said, in the beginning of this year, although it was received, it seems, last year, and it's coming from the University of British Columbia in Canada, from the University of Utah School of Medicine in Salt Lake City, and also from the University of Wisconsin School of Medicine and Public Health in Madison, Wisconsin. They also received a Certificate of Merit Award for an education exhibit at an annual meeting of the Radiological Society of North America a couple of years ago. So, as a matter of introduction, I would like to mention that hip pain is a very common condition, and that's what they emphasized there in the beginning. It has many possible causes, which can, of course, become a challenge, a diagnosing challenge, and also and a challenge for the treatment approach and all of that. So what they mention here is that the injections of different type of mixtures for anesthetic purposes and pain relief for these objectives, they can narrow the list of possible sources of pain, and they can serve as a primary method of managing pain in the meanwhile, as in serving as a bridge to delay surgery as such. So these are some of the important main points, or what they call teaching points, mentioning that the complexity of the hip region and all of the different sources of pain can, as we mentioned, imply quite a challenge for the diagnosis, and then these injections become valuable tools also for the diagnostic and therapeutic applications of and in the approach that they sought. So all these injections, they are focusing on some specific, will detail some of the substances used, but the corticosteroid injections specifically, they have mentioned since time back adverse effects of these that are specific for the corticoid substances, and well, although they're mostly rare, there can be some serious complications, and we'll talk about those more later. There are some common reactions that are transient. They don't last for more than a couple of days usually. So anyway, then they also mentioned that there's an important safety tip to visualize the needle tip. We'll talk about that later, and well, also that the therapeutic injections are elective. We should never choose a patient that's having an active infection in the site of injection, because the risk of seeding the targeted structure is there. We should not distribute the infection, obviously, so we should wait at least a week after they have stopped their antibiotic therapy. So that is that. Also, importance of mentioning that the effect of corticosteroids, mostly the ones that are used, we'll talk about the different types, they give symptomatic relief that begins only after 3 to 4 days after the procedure. So we should let the patient know that it's not an immediate effect. In fact, we'll talk a bit about the corticoid flare, that is an ironic effect where you have pain because of the injection of corticoids. So anyway, there's a paradoxical effect there. But the thing is that, usually this effect lasts for an average of 4 to 6 weeks, which is the benefit of using some of the specific corticoid agents that, as I mentioned, we'll talk about later. So we'll talk about the clinical and imaging findings of common hip conditions, and describing various indications and contraindications and methods of performing ultrasound-guided hip interventions. discussing potential complications and expected outcomes with these procedures. So first, some basic principles of imaging-guided interventions. They mention here under the subtitle of key medications, the big chapter of corticosteroids. Just simply mentioning a few things here because, of course, because of time, there are many things that you will have to refer yourself to the article itself, but trying to emphasize the main points. So triamcinolone acetonide and methylprednisolone acetate are two of the most used substances. These two are insoluble in water. They're called particulate corticosteroids. What they do is, as in these substances, they become a microcrystalline suspension, and they have a slower onset and longer duration. We mentioned that initially. So one of the things that needs to be taken into account is that because these are more prone to give cutaneous atrophy and depigmentation, usually we opt for dexamethasone, which is a hydrosoluble corticosteroid. It's a non-particulate substance, so this is preferred in superficial nerve blocks. We'll also mention later which ones, and that helps us, to avoid the cutaneous atrophy and the depigmentations that are caused by the previously mentioned substances. So yeah, that's just something to keep in mind. I thought that was very interesting. So some of the potential adverse effects of corticosteroids, I mentioned that there were some rare complications and there were some relatively common transient adverse effects. So those that are rare can be quite serious. Septic arthritis. As I mentioned, we need to take care in doing a thorough physical examination and clinical history, so that we can rule out any previous infection, recent infection, or current antibiotic treatment, and wait it out until the patient is eligible for the intervention, until the patient is eligible for the procedure. So we can also have tendon rupture. Something that I read up a bit on chondrotoxicity, it's something that was researched in 2015. There was a Medline and Scopus database search that was published by Stanford University in the Orthopedic Journal of Sports Medicine, under the title "The Effect of Intra-Articular Corticosteroids on Articular Cartilage: A Systematic Review." And it was very interesting. I found there that the following substances, listen to this: methylprednisolone, dexamethasone, hydrocortisone, betamethasone, prednisolone, and triamcinolone were reported to display dose-dependent deleterious, that is harmful, effects on cartilage, morphology, histology, and viability in both in vitro and in vivo models. So saying corticosteroids have been proven to do harm to the articular cartilage. So this is an important thing to keep in mind. Some relatively common adverse effects, but that have a short duration, is the corticosteroid flare, which is a paradoxical pain in the site of injection. And yeah, the good thing is that it explains to the patient that this is something that can happen, but if it happens, it usually doesn't last for long. So then you have others like facial flushing, headache that, as I mentioned before, it doesn't take more than a couple of days in going away, nausea, vomiting, stomach upset. Then, of course, the mentioned issue of hypoglycemia. It's sad to say that steroids are the main cause of drug-induced hyperglycemia. This was published in the World Journal of Diabetes in the same year that I mentioned the other article, 2015. They mentioned that glucocorticoids, of course, it exacerbates hyperglycemia in patients that have diabetes, but it also causes diabetes in patients that didn't have hyperglycemia before, with an incidence that can reach up to 46%. So, I mean, there you have it. I mean, it's quite a strong figure to keep in mind. We need to be clear about all of these possible complications to patients that are submitting themselves to this type of interventions. We know, that the oxidative stress metabolism that glucocorticoids induce have an effect on the lipolysis, peroxylysis, and the hepatic glucose production. So this makes the glucose shoot up, and this is, on the long run, it can be similar to the effects of diabetes type 2 when we speak of insulin resistance and so on. So anyway, enough of that. But then also I wanted to mention that the hypertension phenomenon, all corticosteroid drugs, including prednisone, can cause sodium retention. So it results in dose-related fluid retention. And well, there you have it. I mean, that's the way that it produces hypertension. This was published in US Pharmacist 2008. So an interesting reference there as well. Anyway, so you can also have chest fluttering, which is a sensation of palpitation. Yeah, this usually it's under the subtitle there of common transient adverse effects. Important to explain that it can happen, but it's usually something that goes away before long. Well, continuing on some of the other key medications that are usually injected, we have the hyaluronic acid, which is a viscous supplement. It's present naturally in cartilage and synovial fluid. So this is a substance that is, it's as the glucocorticoids in a way, they are also present in the body, but yeah, they are added. This is endogenous substance, and what it does is that it usually lubricates and regulates the cellular activities in the articulation as of such. And the thing is that in osteoarthritis, you have a reduction of its mechanical and viscoelastic properties. So they have reasoned, well, then we can inject more of it and see what happens. And it has really had very good effects. So this is one of the substances that's used. Also, you have platelet-rich plasma. We know platelets for the coagulation cascades and all that it does there. The thing is that it also has an essential role in tissue healing. So we can activate healing by releasing growth factors, stimulating the release by injecting platelet-rich plasma. This has been shown to give long-term relief and to promote healing at the site of injection. So it's not only used for articulations, it has a wide, broad range of applications. Usually they mention that the platelet concentration needs to be about 5 times the whole blood. So you take out blood of the same patient, you centrifugate it, and you separate it into one part of red blood cells and the other of platelet poor plasma and the other of platelet rich plasma. So yeah, they have the concentration and everything. Just to mention that we should tell our patients to avoid non-steroid anti-inflammatory drugs 2 weeks before and 2 weeks after the application of these. So anyway, there also they have a table that they mention, the recommendations for immobilization, which is 2 to 3 days, and with an early range of motion, according to the pain level. Always the pain level is the threshold, of course, and to initiate physical therapy within a couple of weeks, gradually increasing the activity until 2 months, as to let the substance act, so to speak. So, well, some points to mention when we refer to ultrasound-guided injections is that both safety is a prime matter. We can have a team working or an individual operator approach. So when we work as a team, we have to be sure that there is a good coordination between the team members. If one is using the transducer and another one is using the needle, then there needs to be very good communication as to avoid any type of mishap. We should always visualize the needle tip before advancing towards the target, and the real-time knowledge of the tip location is essential. This is the main point of safety that they mention. We need to know where the tip of the needle is at all times, especially before advancing further. This can prevent unintended consequences of neurovascular injury. So we need to pay attention to that in a very special way. So the equipment can be using a high frequency linear transducer. This is usually what we opt for when it's a superficial target. When we need a more profound reach, we have the possibility of switching to a curvilinear or curved transducer with a bit lower frequency to reach deeper, with the option to switch to that. So usually they use needles of 25 to 30 gauge for the local anesthetic agent at about a bit less than 4 centimeters of depth, and then for the mixture of glucocorticoid itself, a needle of 22 gauge, a bit less than 9 centimeters long. These are the spinal needles. If the body constitution is needing a longer needle, that needs to be taken into account as well, as of course each patient differs. So here, just to mention a bit of the recommendations that they give from their institution about the mixtures. This is an interesting table. Some of the things that I thought interesting here is, of course, we need to check that the lidocaine is preservative free, that it doesn't have any substances of preservation. It needs to be diluted into 1%, so we have a 9-to-1 ratio there. You can use either lidocaine or ropivacaine. Then here they mention the difference between triamcinolone acetonide and the dexamethasone that we mentioned. Here it's very clear that the dexamethasone, we're using it for the superficial nerve blockades. Here we'll mention some pictorial examples of this later. We have the ilioinguinal nerve and also the lateral femoral cutaneous nerve. Those both should use dexamethasone to avoid the atrophy and the skin depigmentation that we mentioned before. So, some risks, just to briefly mention these last points, with pain, infection, bleeding, allergic reaction, risks of the corticosteroids themselves, and some common effects that are self-limiting, and then the serious side effects that usually are rare. So now plunging into the anatomical regions and some examples of each. When we speak of the anterior region of the hip, we have the hip joint itself, the ilioinguinal nerve, and the lateral femoral cutaneous nerve. These are targets for independent procedures. So we'll go into each one of them using the images there. So here we have example of a US-guided hip joint injection where we have an anterior posterior hip radiographs with an overlying drawing. You can see there a light blue rectangle, which is showing the ideal position of the ultrasound probe. It's parallel to the long axis of the femoral neck, and there you have the X. It denotes the skin entry site of the needle. So up there, just next to it, you have an image, which is an actual oblique MR orthogram with an overlying drawing. So this is showing the ideal position of the transducer and the ideal access point for the needle. The needle approach, where you have reaching the deepest concavity of the anterior femoral head-neck junction. You see here the neck, the head, and here the intertrochanteric area. So this is the anterior part again, and we should be reaching this greatest concavity. So here you have another figure. It's from the same series. It's where we have an ultrasound transducer oriented parallel to the long axis of the femoral neck. It's showing the needle. You can clearly see here the needle where the arrowheads are, and we see also the junction of the femoral head here, the head, and the femoral neck. So in this case, the joint has been distended with 1% lidocaine, which is showing as an anechoic fluid here where the asterisk is. So this is confirming the intra-articular position of the needle before you start injecting the corticosteroid. So I thought this really illustrative to include. This is an iliopsoas bursa injection where you have a very neat anatomical illustration here overlaying an anterior-posterior radiograph. So we have the psoas major and the iliacus here. Both muscles, they unite, they pass through the they pass deep to the ingulum ligament, and they form a common distal tendon. It inserts onto the lateral femoral trochanter here, and this deep to this package you have the iliopsoas bursa, which is colored turquoise. So the probe of the ultrasound, which is painted in orange color, is positioned parallel to the inguinal ligament, just above the level of the hip joint. So the X here marks the entry point for the needle in yellow. Here next to it you have a drawing overlaid an actual T1 Wade MR image, and this is showing again the side trajectory of the needle from the lateral to the medial aspect of the patient. So then to complement with ultrasound images, you have here in image C an ultrasound image that's oriented transversely relative to the iliopsoas tendon, and it's showing the needle with the arrowheads, and you can clearly see its tip, which is here marked by the arrow itself. It's just lateral and deep to the iliopsoas tendon, which is here marked by its initials, and it's abutting the underlying ilium. So just touching in here and taking contact with the ilium, the bone surface, as we can clearly see here, the anechoic shadow behind. So here you have the ultrasound image of the same patient with the bursa, with the iliopsoas bursa outlined, and they have instilled here in the injectate, so it becomes distended and it often lifts the iliopsoas tendon off the ilium. So this is important to take into account that it distends. Here you have an ilioinguinal nerve anatomy illustrated by an axial and later by a coronal image. It's from a magnetic resonance T1 Wade images, and what they show here is the course of the ilioinguinal nerve, which is another target of injection. So here the arrow is showing the nerve itself. It's between the internal oblique muscle and the transversus abdominis, which is here shown by both of the arrowheads. So this is in the anterolateral abdominal wall. Remember that this is one of the applications that needs dexamethasone rather than the other crystalates. So because it's a superficial nerve, and yeah, we need to avoid the skin adverse effects. So here you also have same image from a coronal point of view. You have the nerve and the mentioned muscles there. Okay, so in figure 4 you have another type of way of illustrating the same thing. This is also an ilioinguinal nerve block. You have an anteroposterior hip radiograph that shows the target site. It's interestingly enough, it's 2 centimeters medial and 2 centimeters superior, the anterior superior iliac spine. So it's an easy way to reference it off, marked by the X there. And then we have the ultrasound image. It's a color Doppler ultrasound image. You have the probe oriented in an oblique transverse plane, with the medial end of the transducer is directed cranially towards the umbilicus. If you can imagine that, I think you can sort of have that picture in your head. It shows us then the ilioinguinal nerve, very quickly here, next to the circumflex iliac artery, and it's between the internal oblique muscle and the transversus abdominis muscle, just cranial to the anterior superior iliac spine, which is shown here by the bone surface that has a shadow behind. So, just to mention briefly something that they do in the context of the same nerve. Then, in the fourth figure here, we have an ultrasound image obtained in the same orientation as the before mentioned image. Here's where they apply microwave ablation, and what they do is that they apply these cycles of 30 watts at 30 seconds each with a 1 minute interval, and they're using an antenna probe of 17 gauge, about 15 centimeters, also guided by ultrasound. And this is giving a more durable alternative for pain relief. And they follow up this patient as an outpatient at a couple of weeks' time. So yeah, it's an interesting technique. Just thought it interesting to include in this, as it's different from most other ones. Here you have a couple of figures that I put. Is figure 5 and 6. So you have the course of the lateral femoral cutaneous nerve here in yellow in the anterior region of the hip, and it's in the setting of neuralgia paresthetica. It's a condition where you have sensory deficits and paresthesias in the distribution of the anterior lateral thigh, which is the pink region here. It's where you have irritation or injury of this nerve. So this is what they call neuralgia paresthetica. So to briefly jump to the next images, which has to do with the same. Here we have a LFCN block, other than that is keeping in mind the lateral femoral cutaneous nerve, abbreviated. So you have a block of this nerve here. First, you have an axial T1 with MR image, which is showing the location of this of the lateral femoral cutaneous nerve in the arrow. It's surrounded by fat. It's in a superficial facial space outlined in yellow, medial and superficial to the tensor facial lata muscle, which is marked here by TFL, and you have the sartorius muscle in blue, just medial to the same. So then you have the corresponding ultrasound image, which is obtained with a transducer oriented transverse to the thigh. You have the structures that were mentioned previously in the MRI and in the anatomical diagram. So this is the side approach of the needle, and the tip is immediately deep to the nerve itself. So you can see that we're in the space, but the nerve is superficial to the point of our needle. Jumping next to the region of the lateral hip, we have the greater trochanteric bursa and the iliotibial band that we do want to address briefly. We have here in this image a series of images. The actual T1 with MR image of the left hip, where we have the patient oriented in right lateral decubitus position. It's showing you have the anterior surface, the lateral surface in yellow, and then you have the posterior facets of the greater femoral trochanter. So what they are showing here, that you have the typical location of the greater trochanteric bursa, which is showed here in by the white arrowheads, and this greater trochanteric bursa, which is the target of this injection, is just over the posterior aspect of the gluteus medius tendon incision. So the side trajectory of the needle is also shown here with the black arrows. So here we have the corresponding ultrasound images, which is a transverse image showing the greater femoral trochanter with its lateral aspects marked by the white arrow, and the posterior aspect of the greater femoral trochanter. These are the osseous landmarks, so we are injecting here into the greater trochanteric bursa that is overlying these structures. Here, keeping in mind that the asterisk is marking the gluteus medius tendon, means the distal insertion of the same. Here we have another image which is transverse. It's showing the needle in the arrowheads with its tip marked by the arrow in the greater trochanteric bursa, overlying the distal gluteus medius tendon marked by the asterisk again, and the bursa is now distended, so you have an anechoic injectate here, which is marked by the star. Here you have another site of injection, which is the iliotibial band. This is an extended longitudinal use image where we keep the transducer in linear mode and we just continue recording a combined image of it all. And this is showing the relationship of the proximal iliotibial band, which is here marked by the arrowheads, and it's related to the tensor fascia lata and the greater femoral trochanter here, which is marked by GT. So the structure, the iliotibial band, passes just over that. Then in the next series, we have injection at the side of the iliotibial band, where we have first an axial T1 weight MR image. It's obtained with the patient in left lateral decubitus position. It's showing the proper needle trajectory from the posterior to the anterior aspect of the patient at the site of maximal pain. So the needle tip is in the fat plane immediately deep to the iliotibial band. The band itself is marked here by arrowheads, by white arrowheads, and then you have the gluteus medius muscle marked by the asterisk. So also, of course, here you have the osseous landmark, which is the greater femoral trochanter. Here the ultrasound image that helps us to imagine how the actual procedure would be. This is an use image oriented transversely over the greater femoral trochanter. It's showing the proper needle tip position. So the injected medication should spread evenly along the deep surface, which here is marked by the dashed line. Okay, so that's it for lateral hip. Let's mention the posterior hip. We're now in the last part of our presentation, just in case you're wondering. And we're going to talk a bit about the hamstring tendon origin as a site of injection, the ischiogluteal bursa, the piriformis muscle, and the quadratus femoris muscle. So here in figure 10, we're having injection of platelet-rich plasma into the hamstring tendon origin. So here we have first an axial T1 MR image. The drawing is showing here the ideal position of the transducer, and then the needle axis from lateral to medial into the hamstring tendon origin, which is marked here by the asterisk. So you have landmarks, which is the ischial tuberosity, and also you have the proximal femur. The thing is here that we need to be extremely careful to avoid the sciatic nerve, which is marked here by yellow, clearly visible here in the MRI image. Thing is, we need to keep it in mind also in the ultrasound. It needs to be visualized because we need to avoid, of course, affecting the sciatic nerve. So here we have a transverse use image showing the needle by the arrowheads. We see the tip marked by the arrow itself, and the landmark of the ischial tuberosity that serves as an osseous backtop. So we reach that, and we know that that's up until where we can reach. Now, in the following image, we have the ischiogluteal bursa injection as a target for procedure. We have an anterior posterior radiograph of the left hip that is showing the anatomical location of the ischiogluteal bursa, which is shaded in blue, and it's overlying the ischial tuberosity itself. So it's a good diagram. There we have the axial T1 weight image, where we have the patient in a prone position, and we can clearly see the desired trajectory of the needle there. It's from a lateral to medial aspect of the patient, so it's going into the ischiogluteal bursa, which is shaded in blue here, and it's immediately superficial to the ischial tuberosity and to the proximal femur, as we mentioned previously. So this is a quite similar approach. Here we also see the sciatic nerve marked in yellow. They are stressing here again that it must be visualized and avoided during the whole procedure of the injection, as we do want to avoid any mishap related to the neurovascular structures and avoiding injury of the same. So here we have a transverse use image showing the needle. Here it's marked clearly visible by the marking of the white arrowheads, and we can see its tip marked by the arrow. It's in the ischiogluteal bursa, which is overlying the ischial tuberosity, and the hamstring tendon origin. The hamstring tendon origin is here marked by the asterisk. So here it's interesting that they injected a small amount of gas with the medication. It's showing a posterior acoustic shadowing, characteristic of any gas in ultrasound. So the anechoic shadow behind it can help us to delineate the anatomy of the bursa, which helps us then to know that we're in the right place. So yeah, it's making it easier to identify. I thought it was very interesting. So here we have the figure 12 showing the piriformis muscle injection. Here it's an axial T1 with MR image. The patient is again in prone position, and we see the desired trajectory of the needle. It's from the lateral to medial aspect of the patient into the facial plane, marked by the arrowheads between the gluteus maximus muscle and the piriformis muscle. Again, here they're mentioning the fact that the sciatic nerve, also again here, for us to remember, it's marked by the dotted yellow line. And the needle needs to remain superficial to the piriformis muscle, then we will avoid the sciatic nerve itself. So here you have the corresponding ultrasound image. It's showing the sacrum as a bone reference and the greater femoral trochanter. These are the ossal landmarks, and the needle is advancing into the facial plane, as we saw in this diagram. It's in between the gluteus maximus and the piriformis muscle. So if we let the needle advance too far, then we would have a risk of damaging the sciatic nerve. We should always respect here the piriformis muscle as to avoid the sciatic nerve. So here you have an example of ischiofemoral impingement, ending our presentation just now. We have here an axial T1 MR image. This is showing a normal hip with the ischiofemoral space with a white line, and the quadratus femoris space by the yellow line. So it's measured the IFS, the ischiofemoral space. It's measured at the narrowest point between the lateral femoral trochanter and the ischial tuberosity. Whereas the quadratus femoris space is here marked by a yellow line. It's measured between the narrowest point between the lateral femoral trochanter and the hamstring tendon origin, which is just here. So here we have pathologic correlation, image correlation with a pathologic condition. We'll have impingement at this region. We have here in the same type of projection and the actual T1 with MR image, where these same distances are clearly reduced. And here in the actual fat saturated T2 with MR image to the right, we can see the compression that it is causing on the quadratus femoris muscle and the intramuscular edema clearly seen in the T2 with image. We also have degenerative cystic changes, and this confirms the diagnosis of ischiofemoral impingement. This is the last image in our presentation. We have the quadratus femoris injection, where you have the actual T1 with MR image with the patient in a prone position, and then you have the corresponding ultrasound image. So we are seeing the ideal position of the transducer here, both in the MR image and then applied to the ultrasound axis. So what we have here is the ultrasound transducer and the trajectory of the needle. That's clearly seen here in the diagram that they put on top of the MR image, just for us to learn properly how it's done. What we have here is the quadratus femoris muscle, which is shown by QF, the initials. And we also have the ischial tuberosity and the lesser femoral trochanter, the osseous landmarks. Because the sciatic nerve, marked here in yellow, is immediately superficial to the medial aspect of the quadratus femoris, which is our target, we need to keep that in mind. When the needle is advancing, we need to stick to our bone references. I thought this was really interesting because in a way it helps us to relate a bit of other things that are a bit more known to us. When we access doing a drainage of of a pleural effusion, we always respect the lower end of the rib. We can use the rib as a reference, but we should never access the lower or inferior aspect of the rib, because we know that the neurovascular package runs there. This is similar. we can use the lesser femoral trochanter as an osseous landmark, and then we can advance keeping that as a reference, working our way towards the quadratus femoris muscle without approaching anywhere near to the to the sciatic nerve. So I thought that was very illustrative. Here the ultrasound image is showing the same region, and again stressing the need to visualize all the time the sciatic nerve has to approach the quadratus femoris muscle, and here showing the appropriate position of the needle tip marked by the star. Here again, the quadratus femoris muscle and the ischial tuberosity and the lesser femoral trochanter. In conclusion, we mentioned that hip pain is a debilitating condition that has a wide variety of causes, and a proper knowledge of the anatomical regions mentioned can give a key role to the radiologist in the diagnostic examination, the therapeutic management, and helping out through the percutaneous intervention to many times delay the surgery and bring alleviation to this pain. The ultrasound is an ideal modality for the imaging guidance, as it provides real-time visualization of the needle tip without any ionizing radiation. It's usually economically accessible and can be repeated. So we have various advantages with that as a modality for guiding the procedure, although they do mention also the fluoroscopy as an alternative. So we need to be familiar with the interventions that have been mentioned in and around the hip as to be of use, and confident in safely assist and managing hip pain. So thank you so much for paying attention. Hope this has been useful for you. I thought it was very interesting to review these different anatomical sites to learn that there is a big challenge in trying to identify the site of pain, and of course recognizing that if we can rule out one of the possible causes, then we can reduce our differential diagnosis list, and we can help out in reaching final diagnosis. Also, I thought it was interesting to have a critical approach also to the use of corticosteroids, and to be very well aware of the adverse effects that can be produced, as to keep the patient well informed as we approach the procedure itself. So thank you so much once again, and have a very good day.